proceed to the next session, which is again a very important and interesting session on Clostridium difficile and active colitis. To chair this session, we have Professor Chetana Vaishnavi, who is ex-professor of GI microbiology at PGI Chandigarh and has done extensive work on difficile. And we also have Brigadier Atul Sood joining in, who is again from the armed forces. Over to you, the chairpersons.
Hello, am I audible?
Yes, sir, you are audible, sir.
Now we have the next lecture coming in from Dr. Dr. Sahil Khanna, who is the professor of medicine. He'll be talking about infections, Clostridium difficile infection. He's an avid writer and he has significant publications to his credit, and he has special interest on Clostridium difficile. May I request Dr. Sahil to start with his presentation.
Good evening, everyone in India, and thank you to the organizers for allowing me to present on a topic that is very, very, very close to my heart. So I'm going to title this as Managing C. diff in Inflammatory Bowel Disease, Opportunities, Challenges, and Pitfalls. Here are some of my disclosures. None of them are relevant to our presentation today. The outline of my talk over the next 15 odd minutes is going to be, I'm going to talk about the pathophysiology of C. diff and IBD. I'll briefly touch on outcomes, and I'll spend a lot of time on the diagnostic considerations and management of C. diff and IBD. So we'll start with the common case presentation that I see in my clinical practice. A 40-year-old male with ulcerative colitis, well managed on a 5-ASA agent such as mesalamine, presents to the office with worsening diarrhea along with blood and stool. Do a physical exam on him. He appears dehydrated, the abdomen's tender. Based on his physical exam, you decide to admit him to the hospital for an inflammatory bowel disease flare. And one of the first things that you're thinking about when you have an IBD patient who presents with a flare is, did this person pick up an infection? And in our world, the most common infection that we see is Clostridoides difficile or Clostridium difficile infection. I'm going to show you one data slide here, which looked at the percentage of patients with inflammatory bowel disease complicated C. diff. And here you can see that from 2003 to 5, this increased from 4 to 16%. And we also see that our ulcerative colitis patients are much more prone to getting C. diff infection compared to Crohn's ileitis. And Crohn's colitis patients can also get C. diff infection. So why do we worry about C. diff infection? C. diff infection in IBD patients is different from your C. diff infection in non-IBD patients. Patients with inflammatory bowel disease who get C. diff can be younger by about 20 years on an average than patients who get the C. diff without IBD. They're less likely to receive antibiotics, and they're more likely to be community onset compared to your usual C. diff patients who have received antibiotics, and they're more often hospital onset. And why is that? That's because inflammatory bowel disease in itself is a state of gut dysbiosis. We know that IBD leads to decreased variety of useful bacteria in the intestine, predisposing to C. diff infection, just like antibiotic exposure. The other big difference here is the risk of recurrence. We know that since IBD is a persistent dysbiotic state, the dysbiosis persists even after you treat C. diff infection. And the risk of recurrence C. diff in IBD patients is roughly twice that of patients who do not have underlying IBD. And why is that so? This is a cartoon that I'd like to turn your attention to the left side where it says gut homeostasis, where you see lots of regulatory T cells that interact with the intestinal barrier and then with the intestinal lumen, and you have a state of gut homeostasis or no dysbiosis in the intestine. Look on the right side in patients with inflammatory bowel disease, due to the inflammatory milieu in the blood, that then percolates to the intestinal epithelium, we see a state of chronic dysbiosis. Now, we know that chronic dysbiosis is a risk factor for getting C. diff infection, and that's why these patients get in trouble with C. diff infection despite not receiving antibiotics or recent hospitalization or being older than the age of 65. So when we see patients with C. diff and IBD, we're really concerned about this infection because this leads to lots of adverse outcomes in this patient population. There's a longer length of hospital stay by 2 to 4 days. These patients, unfortunately, have a 4-fold higher mortality rate than patients who have IBD alone. C. diff and inflammatory bowel disease leads to subsequent IBD flares and also a lower response to IBD therapy, meaning they tend to lose response to their current IBD therapy and need dose escalation or sometimes switching to a different IBD therapy. These patients have a higher risk of colectomy and other inflammatory bowel disease surgeries. They end up having more ER visits, more hospitalizations, more readmissions. And as I had mentioned earlier, higher recurrences than C. diff patients who do not have underlying IBD. This all leads to high healthcare costs and lots of morbidity for our patients, especially in the era of a pandemic when patients are trying to avoid exposures. And unfortunately, there are lots and lots of diagnostic dilemmas, and it is a diagnostic challenge to diagnose C. diff and inflammatory bowel disease patients. Why is that so? That's because the symptoms overlap considerably. C. diff presents with diarrhea, abdominal pain, and a regular IBD flare without C. diff also presents with diarrhea and abdominal pain and blood in the stool. If you do endoscopic evaluation or even take biopsies, they're not reliable. Pseudomembranes that we typically associate with florid C. diff infection, they're typically not seen in patients who have inflammatory bowel disease and C. diff, even if the C. diff infection is fulminant in those patients. Here you can see on the left, I have a couple pictures of C. diff without inflammatory bowel disease and how pseudomembranes look. But in your patients with ulcerative colitis and Crohn's colitis, if they get C. diff infection, you really can't distinguish based on endoscopic findings. Is this an inflammatory bowel disease flare, or is this C. diff complicated inflammatory bowel disease? And even when you take biopsies, your friendly pathologist is not able to distinguish the difference between C. diff in IBD or an IBD flare in itself. So what do we do? I think we rely on stool tests, but there are some inherent difficulties with stool tests also. The most commonly used test in the United States and some other parts of the world also is a PCR. Now, a PCR is a nucleic acid amplification test, which is very, very sensitive, about more than 95%, but it detects the presence of the bacterium. It does not detect toxin production. It does not detect that if the toxin gene is activated or not, just says the gene is there. And the positive predictive value of a PCR is dependent on symptoms and your clinical suspicion. So if you have somebody who previously had C. diff infection, presents with similar symptoms, and the PCR is positive, you say, yeah, it's probably C. diff infection. But in somebody with overlapping causes of diarrhea, if the PCR is positive, you really don't know if this is colonization or active infection, as a lot of our IBD patients could just be colonized with C. diff infection. Now, when symptoms overlap, as I mentioned earlier, the highly sensitive PCR assay has a low positive predictive value. In this case, C. diff may be a colonizer, and there may not be significant toxin production, and a positive PCR could be clinically irrelevant. The EIA, or the enzyme immunoassay, which detects actual toxin protein, has a low sensitivity, unfortunately, about 50 to 70%. It's highly specific, but you could be missing cases. So with putting all of this together, there is now a two-step algorithm that comprises an antigen called glutamate dehydrogenase and an EIA, which can probably more accurately detect C. diff. And we know that it's important to detect the toxin because patients who are toxin positive have a higher response to antibiotics than toxin negative PCR positive, suggesting that you probably are more likely to have true infection if you're toxin positive. So what's this two-step algorithm? I'll walk you through this. If you have a patient who has symptoms suggestive of C. diff infection, the first step is to obtain GDH by EIA. It's more than 95% sensitive for C. diff for infections, but not specific. So if it's the GDH is positive and the EIA is positive, you then move on to do an enzyme immunoassay. If you have a GDH positive and an EIA positive, you call that as C. diff infection and you have an accurate diagnosis. In some instances, you've got a GDH positive, but the EIA is negative. In that case, you follow that with a PCR-based assay as a tiebreaker because your EIA is not highly sensitive. In that case, if the PCR is positive, you go back to the symptoms, make sure the symptoms are suggestive of C. diff infection, and you can diagnose C. diff. If you've got GDH positive, EIA negative, and your PCR comes back as negative, you could effectively rule out C. diff infection. Now, when you obtain a GDH, and if it turns negative, in most instances, you can rule out C. diff infection, but rarely, if a GDH negative can be followed by an EIA, and if the EIA is positive, if the EIA is negative, again, you can rule out C. diff infection. In that case, then EIA is positive, you go back and obtain a PCR, and if the PCR is positive, you diagnose C. diff infection. So once you make a diagnosis of C. diff infection, the next step is to think about therapy. And I've tried to simplify this in a couple slides here because the therapy is now easier and the guidelines are easier to follow than ever before. Initial C. diff, if somebody has a non-fulminant C. diff infection, meaning they're not in the ICU, they're not in septic shock, you consider them as non-fulminant, and you really don't need to distinguish severe versus mild moderate, except if you're using metronidazole. In this patient population, I truly stay away from metronidazole, and I recommend using vancomycin or fidaxomycin for about 10 days. And I've put a couple stars there. For vancomycin, there's now some data that you may want to use a longer course of vancomycin, and I'll show that to you in the next few slides. And also for fidaxomycin, you may want to extend the fidaxomycin regimen if that's available to you. And for this patient population, you may also want to consider using intravenous basilotuxmap, which is a monoclonal antibody that can reduce your risk of recurrence. Now, once you start therapy on these patients, it's important to keep reassessing these patients. And if after 3 to 4 days of starting your C. diff therapy, they continue to have ongoing symptoms, you may need to escalate their inflammatory bowel disease therapy by increasing their biologics, by adding another dose, and the likes. If you have somebody with initial C. diff that's fulminant, then their treatment recommendations are high-dose oral vancomycin at 500 milligrams 4 times a day, combination with intravenous metronidazole, sometimes rectal vancomycin, and an early surgery consult, because a lot of these patients are headed towards surgery, and these patients need frequent reassessments, sometimes imaging of their abdomen once a day with x-rays to see if they're not developing toxic megacolon. So why this long duration oral vancomycin? This is a nice study that was published in the Red Journal a couple of years ago. They looked at 134 patients, some with Crohn's, some with UC, and they compared what they call as long duration versus short duration vancomycin therapy and looked at recurrence within 8 weeks and also reinfection 8 weeks after ending antibiotics. And here you can see in the graph here that there was a statistically significant, clinically meaningful difference, and the rate of recurrence in patients who received a longer duration vancomycin beyond 21 days was less than 5% compared to more than 10% recurrence rates in patients who received the short duration. There was no difference in reinfections, but at least you could protect your patients with a recurrence rate. Now, there's some fallacies to this study, and in my opinion, if you have to use a longer duration vancomycin, I typically use that as an impulse taper form, and I use that for more than 42 days, and I've seen greater success in that. Fidaxomycin is an interesting drug. It's fairly expensive. Most regimens are 20 capsules. In the United States, it costs more than $3,000 for a 10-day course. This was a study where they looked at extending the fidaxomycin, the 20 capsules, not to take them for 10 days, but to take them for 5 days and then once every other day from day 7 through 25, extending the regimen up to 25 days with the same number of capsules. And this study compared it to vancomycin. And when you look at recurrence rates here, you're seeing very, very low recurrence rates in a vulnerable patient population, which is hospitalized, age over 60. And I sometimes like to extrapolate that data to my IBD patients and say, if I want to treat an IBD patient with fidaxomycin, and I'm using the same number of capsules, I might as well extend it to day 25 and see if they respond better. There are other studies that have shown that fidaxomycin is safe and effective in patients with IBD. These are retrospective, open label, single center experiences that have shown these. So I do prefer to use this agent in this extended form. Now, basilotuxmab is a monoclonal antibody that has been shown to reduce risk of recurrence of C. difficile over 12 weeks in a clinical trial of more than 2,500 patients. And if you look at the pooled analysis here, the recurrence rates were 27% in patients who received placebo compared to 17% who received basilotuxmab, suggesting a 40% recurrence reduction. But who are the patients who benefit from basilo? This study showed that if you are over 65, prior C. diff, immunocompromised, which a lot of our IBD patients are, or if you have severe C. diff or the hypervirulent strain, you have a lower risk of recurrence compared to placebo. So these are the risk factors that I use to see who needs basilotuxmab. This is an IV infusion that you use in addition to your oral antibiotics. And if you've got more than one risk factor, you see that you make a significant difference in your risk of recurrence, and especially if you have more than 3 risk factors. If you've been an IBD patient who has had prior C. diff infection, has age over 65, is an immunocompromised state, this person could very well benefit from basilotuxmab. Now, basilotuxmab has had some experience in IBD. In that same clinical trial, there were about 40-odd patients, some with ulcerative colitis, some with Crohn's. These were younger patients, mostly outpatients, had not received many antibiotics like other IBD patients and were immunocompromised. And in their 12-week follow-up period, there was a trend for recurrence reduction. Now, when you have 40-odd patients, you really can get to statistical significance, but the percentage of recurrence in patients who didn't receive basilotuxmab was over 50%, and it went down to less than 30% in patients who received basilotuxmab. So again, another tool that you can have up your alley to prevent risk of recurrence in these patients. But whatever you do, your IBD patients can get recurrent infection. And the other part of your IBD patients is that when you're trying to manage IBD in C. diff infection, in about 3 to 4 days, if they're still having ongoing IBD symptoms, you want to think about therapy escalation. Careful escalation is safe. This is one study that showed that they compared patients who didn't have any escalation of IBD therapy, or 140-odd patients, to patients who did get escalation of their IBD therapy. And you can see there were no deaths when you escalated IBD therapy. There was one patient with sepsis and several with sepsis who didn't have the escalation, and also the risk of colectomy really decreased. But what is escalation? How do you define escalation? How do you choose between a steroid and a biologic and other therapies that are out there available? So we looked at that in our patient population. We had 137 IBD patients who had concomitant C. diff infection, 70 with ulcerative colitis, 63 with Crohn's, 4 with indeterminate colitis. And we did see that in a retrospective study design that if you gave steroids to these patients as escalation, steroids were a positive predictor for colon surgery down the line at 1 year with an odds ratio close to 6. And this was even significant after we controlled for disease severity. Steroids in itself didn't affect C. diff recurrence, but when we compared that to patients who had escalation by getting an extra dose of biologic, or having a higher dose of biologics, or having extra immunomodulators like azathioprine or infliximab, that was not related to future colon surgery and other adverse outcomes. So if you really have to escalate and you have the ability, I would favor escalating with a biologic or immunomodulator if possible, rather than corticosteroids. And then the adverse events didn't really differ between C. diff antibiotic regimens, meaning vancomycin or others, or which biologic or immunomodulator regimen do you use to escalate. So then it gets to your recurrent C. diff infection. If you have your first recurrence, you should use a vancomycin taper or pulse, or fidaxomycin. And in this patient population, after the first recurrence, the risk of recurrence goes upwards of 50%, and you should consider fecal transplantation in this patient population. If you have somebody with a second recurrence, which does happen in a lot of patients, up to 50% of patients with the first recurrence will get a second recurrence, you typically want to start them on vancomycin or fidaxomycin and then strongly consider fecal transplantation. And that would be standard of care in this patient population for second recurrence. And even for first recurrence, you make that argument. And you would continue your vancomycin or fidaxomycin until 24 to 48 hours before FMT. There are several studies out there, and I've put them in a table form here for your review. The study, the largest number of patients was from our center, 145 patients with 3 or more episodes of C. diff infection, 80% cure rate, about 7% IBD flare rate. But when you look at the IBD flare rate, that ranges from 7% to 50%. So a lot of these patients can potentially get an IBD flare right after fecal transplantation. Now that IBD flares happening due to the C. diff or the fecal transplantation, that's hard to say. But when you look at the success rate, it does range from 80% to more than 90% for eradication of C. diff infection in the next year or so. So these patients can then safely get their inflammatory bowel disease care. So putting all of this together, when you're considering C. diff infection in an inflammatory bowel disease patient, you first try to record their baseline symptoms and the symptoms that they have with a flare so that you're trying to distinguish what symptoms can be attributed to the flare. You look at the modality of testing, and if you're doing just an EIA test, caution, low sensitivity. If you're doing a PCR test, you have false positives. And if you have a two-step algorithm, that's probably your preferred algorithm for testing in this patient population. You find a patient with C. diff, you treat based on the guidelines, based on the number of episodes that they have. Think about prolonging your course of vancomycin or fidaxomycin. But frequently, you need to reassess these patients' symptoms. If symptoms resolve or return to baseline with treatment of C. diff infection, at that time, you don't need any further testing. But if symptoms persist, then you need to think about escalation of your IBD therapy, or if symptoms return after improving, in that case, that those patients could have recurrent C. diff infection. So summarizing everything together, C. diff infection and inflammatory bowel disease is associated with several adverse outcomes, including IBD flares, high rates of recurrence, high mortality, and non-response to IBD therapy. There is a need to escalate IBD therapy, and this can be done safely. There are several diagnostic challenges that remain in C. diff complicating IBD because of overlapping symptoms, and if available, the two-step testing algorithm is the way to go. Vancomycin or fidaxomycin, preferably in a prolonged regimen, are the preferred agents for C. diff and IBD. And for your recurrent C. diff infection, fecal transplantation is safe and effective. Every time when you have a patient with C. diff and IBD, consider evaluating them for an ongoing IBD flare, and careful dose escalation after discussion of risks and benefits with patients when managing these patients is beneficial, and avoid steroids if possible. Thank you very much for your attention.
Thank you so much, Dr. Khanna. One small doubt I had: is there any difference in the dose of vancomycin between a normal CDI and a fulminant CDI?
Yeah, so in a patient who doesn't have fulminant C. diff, we use 125 milligrams 4 times a day. And in your fulminant C. diff patient, you make it 4 times by mouth. And if they have an ileus or impending megacolon, you make it 500 milligrams 4 times a day per rectum also. So they can get a dose of up to 4 grams a day. So about 8 times more, between 4 and 8 times more than your patients who don't have fulminant C. diff infection.
Dr. Chetana is there. Can I request if there's any question from her side?
No, actually, Dr. Khanna, I'm very happy to listen to you. I've been reading about your work so often. And I just wanted to know, you had described one patient of sepsis. Was this sepsis due to C. difficile or due to something else? And do you come across several cases of bacteremia or in this active colitis?
Yeah, so thank you. I think that sepsis in that patient was not due to C. diff. We don't get C. diff bacteremia. C. diff bacteremia extremely uncommon. The sepsis that these patients get is from the colitis itself and the SIRS response that happens from the colitis itself.
Oh, okay.
Looks like there's a few questions.
There
Go ahead,
are one or two questions.
Yeah. The question on the chat. Go ahead.
One is, how do we define refractory Clostridium difficile in IBD?
That's a very, very good question. It's almost impossible to know if your symptoms are due to C. diff, ongoing C. diff, or inflammatory bowel disease flare. We know that a lot of our patients have a good response to oral vancomycin or oral fidaxomycin. And in this case, a lot of times when you have your C. diff patients with inflammatory bowel disease, If they have no response whatsoever, you could call it refractory, or is it an inflammatory bowel disease flare? At that time, it becomes a clinical decision. You can look at other parameters such as their white count. You can look at their CRP, but most of these times you need to treat C. diff and inflammatory bowel disease concomitantly. And the other part of that question is, how do you differentiate symptoms from IBD? It's almost impossible to distinguish symptoms of C. diff and inflammatory bowel disease because they are overlapping.
Do you isolate patients?
Yeah. Regarding isolating a patient with C. diff infection, universally, if they're hospitalized, you should isolate them with contact precautions. And if they're at home, I also try to ask them to use a separate bathroom if possible, bleach clean their kitchen and bathroom surfaces, wash their hands with soap and water as much as possible. There's a question regarding how do we diagnose recurrent C. diff infection in patients with IBD? Could PCR and EIV false positive if previous history of C. diff? So the recurrence, usually we do it with symptoms and testing put together. PCR can definitely be false positive. False positives, EIAs, are very, very rare. So if you have to truly diagnose recurrent C. diff infection, you put symptoms and testing together. And I would favor using a two-step algorithm with a GDH followed by EIA and arbitrated by a PCR. Let's say if you don't have a GDH followed by EIA and you just have a PCR, then you can put one extra realm to it where if you have a PCR positive, you start treating that patient with vancomycin or fidaxomycin. And if they improve somewhat, then you say that this patient probably has C. diff infection. That was a true infection. A response to therapy can also be used.
So this was a very nice and lucid talk, very concise, and I'm very happy to have seen you through this virtual conference. And at this time, I also want to thank all the organizers, particularly Dr. Vishal Sharma and Dr. Usha Datta, for including me in this splendid academic feast. Thank you very much.
Thank you very much. And I would say
thank you, Dr. Khanna. Thank you, Dr. Khanna. Yeah.
Special thanks to Vishal, who's my friend for more than 2 decades now. And we've spent a lot of time reading physics books together over the years.
Thank you, Sahil, for joining in and for such a lucid talk. Thank you so much. With this, I thank the chairpersons also, and we proceed on to the next talk, for which we have very